Good evening to everybody and happy Republic Day. This is the important day for the nation, and hopefully, this translates to us as a community. It's my privilege to introduce Dr. Mudit Mittal. Dr. Mudit Mittal practices in the center of India, so to speak, which is Bhopal, Madhya Pradesh. Extremely well trained, trained in all aspects of ENT, has written books, has published
Vertigo.
research articles, has worked in all fields of ENT, and also has an interest in neurotology. So I want him to share with him his experiences. But before that, I just want to introduce another panelist of ours. Rajiv, are you there?
Yes, sir. Good evening.
Hi.
Hi, sir.
So, Dr. Rajiv, now would you like me to flatter you or would you like to introduce yourself?
No, sir. I can only describe myself as a co-seeker of knowledge along with you on this journey. And to shorten my resume, I became a professor of ENT a few months ago, and then now I have entered private practice. I have one publication in Vertigo, and I think rather than words, action should be important. So we'll just start off the session.
No, I think you're not doing justice to yourself. Dr. Mudit is an extremely well qualified doctor. In addition to ENT, he also holds degrees in hospital management from Birla Institute, Pilani. He also has a postgraduate diploma in medical law and ethics from the National Law School. He knows many languages, including Sanskrit, which I think is something. Am I right?
Dr.
Yes,
Rajiv.
sir. Yes, just a student.
Oh, well, whatever. He has a lot of publications. So when he says I have only one publication, it may be in the field, but he has publications from all areas, and therefore he's somebody I'd really look forward to having as a expert panelist. So now, without further ado, Dr. Mudit, can I invite you to commence your presentation, and then we will discuss it after the presentation is over.
So thank you, Naya sir, and thank you Cyclops team for having me here. Good evening, everyone. Share screen share. So can you see my screen?
Yeah, your screen is visible.
Yes, sir.
All right.
It's visible.
All right. Shall I start?
Yeah.
So actually, the topic is diagnosing emergency in undifferentiated acute vertigo. Very frankly speaking, this is my first publication in vertigo section, and this is not a paper. This is my journey. It was a joke in between our residents that when a patient of vertigo enters in our clinic, all the residents started getting vertigo by themselves. It was such a complex topic, such a broad diagnosis, how to approach, how to handle, what to do. So it was very difficult. So this started as a journey, and I just wanted to make things a little bit easier for myself and for my fellow residents. How to do it, how to handle it. Now, the first question which arose was, what is vertigo? Now, we do not have very right lexicon to describe the word vertigo, dizziness for everyone. This explains something different. Is it okay?
Yeah, go ahead, please go ahead.
So for everyone, this is something different.
Yeah.
Like the balance system is a sixth sense, which was undiscovered for centuries, at least in a part, because it operates below the level of conscious perception most of the time. And dizziness overlaps within verbal description, and there is no consistency. So next obvious question is that what is balance? So balance is defined as the ability to maintain your center of mass over your base of support. It's a very complex thing. It involves multiple systems that interact flawlessly and automatically to coordinate inputs from our environment and the central nervous system to produce a motor output that keeps you upright or vertical. Now, if we add dynamics into it, it becomes postural control. For somebody who boos out and loses his equilibrium, it must be fun. For some other, it may be a very bad experience. So, ambiguity about when one tries to interpret another's lament of equilibrium loss, it's very difficult to understand what exactly is happening with the person who is sitting in front of us. Therefore, probably this undifferentiated acute vertigo with such a broad differential has been termed as syndrome. It is called as acute vestibular syndrome. What are the characteristic of it? It's rapid onset of severe, often disabling illusion of movement with nausea, vomiting, head movement intolerance may or may not be associated with gait unsteadiness or nystagmus. Now, the cerebellar brainstem stroke is the most feared complication. This most feared cause of vertigo, which may lead to increased disability or death. Many patients present with neurological symptoms such as limb weakness or paresthesia, diplopia, dysarthria, but some present without these features. As such, the condition may resemble vestibular neuronitis. So this again becomes very confusing. Now, what are the challenges? The evaluation of dizzy patient can be overwhelming due to broad differential. Second, patient often have difficulty to describe their symptoms. They often give a very conflicting information at different times. Then there is added anxiety. Anxiety may significantly increase the risk of dramatic presentation and recurrences. With the clinician, he feels like there is a fear of missing stroke and urgent need to intervene so as not to miss the best time for treatment strategies. Clinician need to address the cardiovascular risk factors to reduce the chance of developing future complication. With limited resources, he has to also increase the resource efficiency. And nowadays, I had to avoid the malpractice litigation also. So the perplexed clinician needs to pursue with advanced diagnostic imaging, neuroimaging, CT and MRI, magnetic resonance imaging, and sometimes unnecessary hospital admissions in these patients. CT and MRI. Now, many papers, many reports have suggested that CT and MRI suffer from a poor sensitivity for early stroke and misdiagnosis rate is high. But there is one physiological test we can bank upon, and reports have also shown that HINTS is more sensitive and neuroimaging method, more sensitive than neuroimaging method in distinguishing stroke. We all know what is HINTS. Now I am talking about HINTS plus. This is a 4-component test. So first component is head impulse test, second is nystagmus, third is test of skew, and hearing assessment. This is the 4th component, hearing assessment, which has been added in standard HINTS test. So the aim of this study was, first thing, we in Indian subcontinent, we do not have very good data regarding how many patients we have, what exactly is happening with these patients. Globally, there probably we developed these tools a little late than the Western world. This may be a reason we do not find much literature about how much penetration of this problem in our society is. Second thing, for clinician, this is a very complex problem how to manage these patients with acute undifferentiated vertigos presenting within 72 hours of onset of symptoms. Now, why it is necessary to register these patients with video oculography and audiometry? This is what we have added in this study. Because video oculography and audiometry. First of all, for ENTs, this is the tool which is easily available. Nobody else can read these tools or the results of these tools better than us. And it is now very much available to everyone. This also brings standardization and optimization of hints. With the help of video oculography and audiometry, we can improve the reproducibility. Now, with this help, there is shortened learning curve and residents can be trained. There is increased reliability and practicality. We can go back, we can learn, we can come back. So next is the methodology. So this is the data of patients from August 2021 to 2023. This is around 82 patients data. Now as the paper has been published, now this data is even a little bigger. As I explained that it is very difficult to define dizziness. This frequently means that even after exhaustive inquiry, it will still not be entirely clear. What exactly is the patient feeling wrong, and even less so why he feels it. So we have to have an inclusion criteria in that. Acute onset of vertigo and dizziness as the main manifestation should be in the inclusion criteria. These patients should report within 72 hours of onset of symptom. Why 72 hours? See, in clinical scenario here at my place, it's not necessary that patient will report within 24 hours to my center. So we have to have a window of it. So those patients who have reported within 72 hours of onset of symptoms, age must be greater than 18 years. These patients with or without nausea, vomiting, head movement intolerance, gait unsteadiness, headache, numbness, speech abnormality, diplopia, facial weakness, dysarthria, limb numbness, and weakness, eye movement disorders were taken into consideration. We did excluded some patients from this study. Obvious causes of dizziness such as hypoglycemia, high-grade fever, influence of medication or alcohol uses, pregnant women, autoimmune or neoplastic disorders. Now, this was the workflow. See, as I said that clinician need not to get a vertigo when they see a patient of vertigo. If we already this is very complex. What I feel in my brain is this is very complex. So I wanted to make things simpler so that it can be expressed to everyone. So keeping it simple, a meticulous history and clinical data, including age, gender, history of chronic illness like hypertension, diabetes, heart disease, overweight, lack of exercise, smoking, alcohol, previous history of stroke was collected. And those patients with transient vertigo and unidirectional nystagmus were segregated. These patients were treated with appropriate rehabilitation exercises. Now, those patients with ongoing vertigo, with uni or bidirectional nystagmus, and presence of other focal signs such as gait unsteadiness or what I have expressed in previous slides. So these patients were taken for hints plus examination. A complete hints plus examination was done. And if any of these patients come out to be positive, these patients, now here there is one more discrepancy in the lexicon. See, hints includes 4 components: head impulse test, nystagmus test of skew, and audiological test. Now, if head impulse test is positive, now this is the patient with reassuring results. However, the skew deviation is positive. Now, this is a worrisome result. So probably this terminology as hints plus positive and hints plus negative also is not very appropriate. Probably I'll keep it like hints plus examination, those who tested reassuring results and those who had worrisome results. So those who had reassuring results were treated for vestibular neuronitis, and those who had some worrisome results were taken for neurological and CVS examination. They were evaluated radiologically or other investigation as required by the respective specialist clinicians. Of those who came out clear from neurological and cardiovascular assessment were then taken for video oculography and treated accordingly. So this was the workflow. Now, these are the results. So these are the results. So canonical standards for AVS diagnosis requires the presence of persistent vertigo for more than 24 hours. That's why we have taken those patients who have been reporting to us within 72 hours. Epidemiology regarding India is not very much available. However, dizziness and vertigo accounts for about 3 to 4 million visits in emergency annually in United States. I asked one of my, on a lighter note, I asked one of my senior ENT colleague here in Bhopal, and I asked him, what do you think, what is the penetration of patients suffering from vertigo here in Bhopal? And he said that, क्या मुदित क्या बात करता है, आधे भोपाल को चक्कर आ रहे हैं. So it's not very defined what exactly is the penetration. Now, out of these number of 3 to 4 million visits, only 0.7 to 4% of them receive a diagnosis of ischemic stroke. So in our study, we had 82 patients with undifferentiated acute dizziness, and we assessed them. Overall dominance of female patient was 68% in total number of patients. Now, it has been reported in previous studies also that females suffer more from dizziness-like complaints. This is the spectrum of acute undifferentiated vertigo. Peripheral vertigo, vestibular causes accounts for 84%, and 65% were diagnosed with BPPV, 18% vestibular neuronitis, and 12% with established stroke. And our study was also consistent with the previous studies, where in previous studies it has been showed that 2 to 25% of patient can have cerebrovascular events. Peripheral causes of vertigo. In peripheral causes of vertigo, 27% were male, 73% were female. However, in central causes of vertigo, 77% were male and 23% were female. So men tends to experience more central causes of vertigo because of more frequent cerebrovascular diseases. Most stroke patients with dizziness symptoms have other neurological features also, such as face arm weakness or numbness or speech language abnormality to indicate the central lesions. Patient visiting with symptoms of acute dizziness and vertigo and those who did not receive a diagnosis of stroke suffer twofold higher risk of subsequent vascular events after adjusting for patient's characteristic comorbidities and other confounding factors during first year. So when we are seeing patients and sometimes when we are not diagnosing stroke and we are sending those patients to home, so there is an increased risk of these patients getting stroke. Now, some patients can present without neurological features. As such, the condition may resemble vestibular neuritis. Now, there is a lack of overall diagnostic accuracy to rule out the dangerous vestibular causes. Because of this, roughly 1 million are over-tested, hundreds of millions of dollars spent on brain imaging, hospital admission, still misdiagnosed, still undertreated, CT MRI doesn't work. What to do next? So, who to do test for HINTS plus? Only patients with persistent ongoing vertigo. This is a very good paper from Newman Toker. This was published in Journal of Emergency Medicine, and they explained it using the physical examination to diagnose patient with acute dizziness and vertigo. So this is only for the patient with persistent vertigo. This is the sensitivity and specificity of HINTS plus in our settings. The sensitivity of HINTS is 100%. In isolating central causes of acute undifferentiated vertigo, the specificity was 94.5%. Let's talk about the structural neuroimaging. In different studies, CT and MRI found to have misdiagnosis rate ranging from 12 to 60% within 48 hours of various studies. Although false positive stroke reporting by MRI is relatively outdated because of advancement of technology, however, even if structural neuroimaging improves in future, physiology will still likely to win. Because as soon as the patient becomes symptomatic with acute vertigo, oculomotor physiology changes instantaneously. So oculomotor physiology based diagnosis, that is head impulse test, has proven to be more accurate than even diffusion weighted MRI when correctly applied. Video oculography devices measure key eye movements, can help in diagnosing and training and reproducing the results. So next question is, can hint fail? In anterior inferior cerebellar artery stroke, that is labyrinthine infarction, rarely in basilar artery occlusion, and posterior inferior cerebellar artery, there will be reassuring hint result, which mimic vestibular neuronitis. However, large skew deviation and hearing loss is frequently present in these patients. This was a paper from Hayden et al., who advocated a combined approach in such patients unless proven otherwise. There can be certain obvious conditions when hint cannot be performed, such as head trauma, neck trauma, unstable spine, neck pain. And it's true that one cannot diagnose all the causes of vertigo by this way, but most of the other causes of vertigo are rare and will also have some indicating features at the time of presentation that will suggest that it's not an isolated vertigo and may give clinician enough time for diagnosis. So to conclude, the sensitivity and specificity of HINTS Plus 4-component test has found to be very high in identifying central causes of undifferentiated acute vestibular disorder compared to CT and MRI in first 72 hours of onset of symptoms. Second, HINTS Plus based workflow is evidence-based, low cost, easy to carry out and learn. Third, with improved technical equipments like VOG and audiometry, it is effectively improves the diagnosis and significantly reduces the chances of a miss. Reproducibility of result is strong and learning curve is short. Patients can be treated with fair confidence. There are quite some weaknesses of these studies, like subjective bias, which can be minimized with the help of VOG and audiometry, confounding bias, limited data. This needs a large volume study. And this was a paper which finally got published in Indian Journal. These are some references, and I conclude my presentation over here.
Thank you, Dr. Mudit. I think first and foremost, I must appreciate that with a busy practice, you took time out to do this study. That's not very common. I must appreciate the fact that you managed to do it, because many people working alone would have given up midway through it. So hats off to you. Did you do it in your practice or in the institution is the first question which comes to mind.
So, sir, this is in my practice. I have a VNG lab over here in my system.
Good. So now let me start with throwing this open for discussion with the panelists. Now, we are fortunate to have two panelists. One is Dr. Rajiv, whom I introduced, and the other is Dr. Kripa. I wonder if Kripa would turn on her video so that we could see her. Hi, Kripa, could you just...
Hi, sir. Good evening to all. Sir, I would have loved to. Only thing, I'm in a little low range area. That's the reason, I don't want the video to...
okay, fine. No problem.
Between.
No problem. So, briefly, Dr. Kripa is well trained. She is one of us. She has trained in the Cyclops MedTech clinic, tertiary referral clinic in Bangalore. She is now setting base in Bombay. So hopefully she will bring the same quality of work in Bombay with all the equipment which is available with us. We would be duplicating the disease clinic in Bombay. So we look forward to a lot of inputs from you.
Thank you so much.
We start off with a couple of questions. Now, I'm going to really throw a googly to begin with. We agree that data is sparse in India. We agree that this is not easy to diagnose. So I just want now the level of discussion to go to the next level. What are the possibilities that machine learning and artificial intelligence would step into this area even before the residents wake up? Dr. Rajiv.
Yes, sir. I was just going through an article. It's titled as Neurology Review, Neurotology 23 in the Journal of Neurology. The first author is Professor Halmagi. So, in the last part of this, he has commented about machine learning
And of course,
and
everybody knows Halmagi is the person behind the head
head
impulse
impulse test.
test.
Yes,
Go
sir.
on.
Yes.
Yeah.
So, in the last few paragraphs, he has commented about machine learning, and there are already a couple of papers which have reported how machine learning algorithms can identify nystagmus even from low quality videos. And there is a chance that we might get an AI assistant soon, which might use patient questionnaires and even machine learning algorithm to identify the nystagmus and arrive at a diagnosis. So this would be a big boost to clinicians everywhere. Uh,
Well, I'm not sure if it's a big boost to clinicians or it would be viewed as a big threat to clinicians, which is why I tossed the question. But I'd love to
Probably.
have Dr. Kripa's opinion. Could you share with us what you are doing in this regard?
Sure, sir. So the way I look at it, we can definitely use it to our advantage also, rather than being threatened by it. Yes, patients, which the nystagmus will be picked up early, even by the beginners, is the way I look at it. And then we don't miss a diagnosis. And if we have a diagnosis, we can treat that. That is the whole point.
Good. So, I mean, the reason why I pulled you in is you are
Yes,
also working on on an early attempt to start doing our own AI and ML in this regard, and so I think this
yes,
is something which everybody should know. Everybody who's attending, that this is a clear and present area which people are working on, and therefore we need to start codifying early, one from the viewpoint of our developing experience, and second from the viewpoint of helping the machine learn correctly. So
yes.
we will soon be reaching out to everybody, trying to get codified, uh, not for any personal profit, but because we need to make an India perspective in this regard. Right. So I think that is the point one. Now, to bring it down to a more basal level, um, Dr. Mudit talked correctly about hints and hints plus, where he added audiometry to the practice. So now I'm going to reverse the order. Kripa, can you hear me? Can I ask you a question or should I come to you later?
So whichever, I'm fine
Okay,
with
so
both.
Kripa, here's the question. When you add audiometry to hints,
Hmm.
how feasible is it in an emergency?
Yes, so that's a good question. But for example, in a there is in labyrinthitis, along with vertigo, there's a definite hearing loss. We know that, rather than in a case of vestibular neuronitis, where there'll not be a hearing loss more prominently. But an audiogram in these patients, I mean, there comes the challenge of patient cooperating and actually having a fair, we getting a fair result. So I feel we can, we can go by more of clinical insight rather than an audiometry in these cases.
What about you, Dr. Rajiv? What do you think?
Sir, perhaps classical complete pure tone audiometry would be difficult. In cooperative patients, it's possible, but maybe we could consider other forms of audiometry, such as photoacoustic emissions. Though the sensitivity is low, it would probably give us some information in such cases where we are suspecting a cochlear pathology. In
So
that
now
case,
we put that question to Dr. Mudit. In your experience, how happy were you doing? Because you have a series of 75 cases. How happy were you in doing audiometry?
So, sir,
I mean, this is an area of worry for me. That's why I'm asking.
yeah.
Yeah.
So,
Trusting
yeah,
you in this.
those patients who clinically we can see that these patients can help, we can get the audiometry done, and patients are also wants to know about the things and they are ready to cooperate. We can get an audiometry at the same time, just we have to get a pure tone audiometry for gross 5-6 frequencies. Now those patients who are unable to cooperate, we can get information with the help of tuning forks also. So tuning fork gives us a very good information. We can register that. However, what audiometry can give us is more reproducibility. With tuning forks, probably we might not get that. However, it works well. Tuning fork also works well.
Okay, so I mean, in summary, you would say that it is possible, maybe not in all, but you feel it is something which we should try.
Yeah.
Definitely.
Yeah.
Because, I'm not too sure in
It's
institutions
not.
how easy it is to get an audiometry done in an emergency. When I first read the papers, I was very skeptical on that score.
Exactly,
So
sir.
maybe we all need to look at that again, and maybe that could be worthy of a separate paper, Dr. Mudit. You could actually publish a paper on feasibility in audiometry in an emergency in institutions. I think maybe it's because it's in your private practice, it would be easier.
So my audiologist is very well trained for these patients. We do not do very exhaustive audiometry. We just take few frequencies and we go through them, and we go through really fast.
No, I think so. So that is something which many people working in institutions would have a problem with. And that's
True.
what I tend to feel. Anybody wants to comment on that? Any of the
Yes, sir. So in the institutions, I definitely agree because availability of the equipment, manpower, apart from the patient themselves.
Yeah.
But there are screening audiometers which can be used. They're relatively low cost, so I think they can be considered in the emergency setup. But again, we need more experience, and getting experienced people in the middle of the night would probably be a difficult proposition.
Me getting up in the middle of the night itself is difficult, but I understand what you. If I think I could just briefly open the window to anybody who wants to comment. Does anybody do hints plus with audiogram in this group of 40 attendees? You could just welcome to speak up.
Sir, one small thing I would like to add. See, for example, okay, I agree that the equipment might be a challenge. The audiologist might be a beginner, a fresher, or an expert. But the thing is, for example, in patients like stroke who have the dangerous D's in them, dysarthria, they have they have drowsiness. How do we expect those kind of patients to cooperate? Is something which
So then I think Dr. Modit had already categorized them separately. Am I right?
Yeah.
Okay.
You do not need to.
You don't need to do that. So the next question, which I hope you don't mind, a slightly pedantic style, but because you're presented with a study, I think we would just look at certain issues which are interesting. You chose to do your study on above 18 people. I assume because 18 is the arbitrary pediatric department's reach. So nowadays, I think there are some workshops happening and a lot of interest in pediatric vertigo. So the question to both the panelists, anybody could take this. How often do you find pediatric patients with stroke? How often do you find this to be an issue?
So never seen one, not yet.
Yes, sir. I haven't been referred any pediatric patient having a stroke and symptom of vertigo.
So then
that
I'll switch the
combination.
question. How often do you see pediatric vertigo itself?
Maybe a couple of cases in a year.
Yeah.
Rupa, go ahead.
At our Bangalore center in the last month, every week I had one patient. Yes.
Okay, so that's a very high
Yes,
percentage. How about you, Dr. Mudit? What is your experience?
Sir, I am associated.
Yes.
So, no, I'll come back to you, Kripa. Tell me, Mudit.
Sir, I am associated with two big pediatric hospitals over here. But I haven't been given a single call for a pediatric vertigo yet.
You must be called by the mother who can't handle too many children, right? कि पता नहीं इनको कैसे देखें. But go on, Kripa, tell me something about your experience.
Sir, anything specific like you
No,
want
so
to?
just give us a broad idea of your patients.
Right, sir.
Pediatric.
Right, sir. So most of these cases I felt were cases of BPVC, that is benign paroxysmal vertigo of childhood, where the child gets very brief, he's playing normally, very brief attacks of, disabling vertigo, like as good as he comes and clenches to the mother, and the next moment he starts playing again. But this is again an extension of vestibular migraine, and in most of these patients, the mother or the mother mostly, there was a strong family history, is what I noticed. And in only one of them, he had a preceding fever. He had a preceding upper respiratory tract and a fever before this. And 10 days later, the patient presented with severe vertigo, disabling enough to make him throw up. And yes, so most of them, sir, I feel were migraine.
So
Yeah.
that, I mean, that's good. I think we are opening up this a little. The next question which came to mind when we were looking at the presentation is, um, how do you actually treat the patients? You do you have a referral format with the neurologist, or are you treating them jointly, or what would you do? As I mean, let's assume that you have a clinic and you see a patient where you suspect he has some intracranial problem, and very high incidence of cases whose MRI is normal. What do you do?
So yes, I have a referral neurologist with me and a cardiologist with me who these two guys are also very enthusiastic about vertigo. So this is fortunate for me that these guys are very much enthusiastic about this. So I have to send these patients to them.
But
And
suppose they find the MRI is negative, what do they do?
so if they clear off these patients from central causes or cardiovascular causes, they send me back the patients, and then I start doing their vestibular testing, video nystagmographies, and then I try to figure out what
So
I'm
would you
missing.
have done the VNG before, or would you do the VNG only if it comes
So,
back
so
to
I
you?
use VNG as a very loose tool. I sometimes use VNG when I'm not getting exactly what kind of nystagmus it is, or for hints also I use a high-speed video camera with me along with my nystagmogram, video nystagmogram. And once I get something out of it, and if I feel that the patient I need to send to neuro, I send those patients to neuro. If they come back to me, then I'll get the whole complete testing done with all the maneuvers also. Otherwise, I use it as a diagnostic tool, just like a Frenzel glasses.
Okay.
I take them anytime.
Okay. And how would you treat them medically, or what would you do?
Uh, which patients are
Of the patients who have come back from the
coming
neurologist?
back to
Yeah,
me?
that right.
Most of the time, what my experience is, these patients are of vestibular migraines. So I feel that vestibular migraine is an entity which is like BPPV is overdiagnosed thing. Vestibular migraine is underdiagnosed thing.
Agreed, sir. That is true.
Okay. And and then how would you treat? What if, I mean, if you would share your treatment secrets, if you would consider it like that?
So I have a vestibular migraine protocol with me. It has some antidepressant amitriptyline medications like this. Then there are some exercises also. We get involved with exercises and some do's and do nots. Some food also. Those are there that they are not supposed to take. Flickering screens, much of mobile and television uses, coming back to exercises, and all those kind of activities, and then we follow them for 4 weeks or 5 weeks, and then we find what's going on with them.
And how beneficial do you find medical treatment in general? Because the
Amazing.
neurologists are usually very frustrated with migraine.
My practice, I get wonderful results with all these things combined. So alone medicine won't work. I explain this thing to patient, that it's 30% job of medicine, 30% job of your do's and do not, and 30% is exercises. Probably in 4 or 5 weeks, you will be start getting some 70-80% relief. And I'm getting it.
And how many of them have coexisting migraine, or how many of them are purely vestibular migraine?
So I have to pull my data sheet, I think,
No,
regarding
just
this.
give me a
So
ballpark idea.
if I see, if I diagnose some 10 vestibular migraine, I think that only 1 or 2 are already having a diagnosis of migraine, or previously have been treated for migraine once on a time, or I probably missed it in history taking, that they have been previously treated for migraine. Hardly 1 or 2 in 10.
Okay. So, Dr. Rajiv, would you like to share your experience here?
Yes, sir. So I have had a few cases where central cause of vertigo was there. And interestingly, some of them turned out to be Parkinson's disease with borderline clinical feature of Parkinson's. So a couple of them were diagnosed as Parkinson's, and the neurologist started treatment. But the others who had these borderline features of Parkinsonism, the neurologist also refused to start any pharmacotherapy. So then it was a long process. Now, before ruling out the peripheral vestibular conditions clinically, I usually send them for VNG or other testing to document the findings. And then if the patient comes back after that, so in a place like Bangalore, of course, most of them are lost once there is a to and fro between specialists. But if the patient comes back, then it's a long process of explanation and educating the patient. And some of them did follow up with me afterwards, and they did turn out to have Parkinson's later on. So
Interesting.
there are other neurological conditions with a normal MRI, which most of the neurologists find it very cumbersome to diagnose.
Yes, sir.
That's interesting.
Uh,
Kripa, your
yeah.
opinion?
Yes, sir. Sir, I agree with Dr. Rajiv here. One small thing I would like to add, that many of these MRI negative strokes are sometimes multiple sclerosis, especially because they present as small demyelinating lesions within the brainstem and which are missed on an MRI. So multiple sclerosis is something we should keep in mind, apart from, of course, as added by Dr. Rajiv, Parkinson's.
And I think you have a lot of experience with migraine, so you would
Yes, sir.
think migraine is something you place high in your differential.
Absolutely, sir. So MRI negative strokes are, could rather one could be an MRI negatives whenever it comes to vestibular migraine, TIAs or early strokes can be another differential, sir. Yeah. Also,
You mean
always, yes, sir.
stroke in evolution?
Yes, sir.
Or
TIAs or
yeah,
a very early,
Interesting.
yeah,
yes, sir. So,
that's stroke in evolution, early spectrum. Yeah.
yes, sir. Or
So
very brief.
how often would you think you would have a coexisting lesion? Because see, Parkinsonisms and all those conditions are increasingly common,
Correct.
and
Uh,
vertigo could be a kind of a comorbid lesion, not really a cause or an effect or something like that.
Yes, sir. Sir, for this, what happens is like for conditions like Parkinsonism to present, vertigo is a late feature in Parkinson's patients, is what I feel. So by the time the patient presents to us, he would have already had the other more classic symptoms and would land up with a neurologist rather. But a case of say progressive supranuclear palsy, where where falls or where vertigo could be an early manifestation. That is what I'm trying to say. Ki by the time vertigo presents, the other full-blown features would already be there. So these patients would
Yeah, so
most
now
of the time,
I take your point, but my only point which I would like you all to consider is
yes, sir.
uh, there is no rule that a person, an elderly patient, cannot have vertigo arising de novo. He may have a lot of
Absolutely.
other conditions.
Yes, very much.
He could have BPPV anyway by itself. Uh,
Yes,
we are
sir.
we are trying to link them together. I am personally a bit sort of cautious here. I sometimes feel we need to treat vertigo as vertigo and Parkinsonism as Parkinsonism and not mix the two. This is this thing, but again, I don't have any data or study to base it on. It's just a suspicion. If you want to comment on that, you're free. You could criticize it. I'm open to that. Mudit, would you like to say anything or on that? No.
No, nothing, sir.
Okay, so here we come to, of course, I should have started with this was a very interesting thing. Vertigo and female and male. I don't want to sound sexist or racist here, but why would you think that vertigo is more common with females? Data aside, but why should vertigo be more common in females? Any thoughts?
So
Sir,
me,
Anybody?
Rajesh, sir, please go ahead.
Don't ask me because then I'll get in trouble. But maybe you guys can.
sir, there are several conditions which are underdiagnosed in women, especially middle-aged women. Autoimmune inner ear disease is one such condition because autoimmune disease itself is a neglected entity, and it is either ignored or it is not explained to the patient at all. And investigations and treatment are still in a very nebulous phase. Nobody knows how to manage many of these cases. So I think there is still a lot in medicine which is not adequately understood or treated enough. This is one of the examples. That's why probably in women, especially in the middle age, we have many of them who complain of vertigo, but we don't know what's happening.
Okay, so this might interest you, but in Cyclops, and I'd love to have you join in on that. We are considering a study which is studying allergy and vertigo in all its manifestations. So I think I would like to get a pooled resources of everybody because one person may see only a fixed number, but as a group we can actually raise a good number of patients who have the dual problems of allergy and vertigo. So we can have substantial numbers to prove, to disprove, to at least epidemiologically classify. So I think Dr. Rajiv, you also have experience in allergy, if I'm not mistaken.
Yes,
Right?
sir.
You've done
Actually,
some
I was
qualifications.
running an allergy clinic at Ramaya for a while.
So I think we'd love to have you on board in this study. And in fact, of all the people who are attending, if anybody is interested, please reach out and we'd be happy to involve you in that study. No, I mean, risks, patients, anonymization, everything, and we'll help with getting the study on road. So hopefully a couple of 6 months or 1 year down the road, we'll be able to jointly present the presence or absence of allergy. Dr. Mudit, would you like to comment on allergy and vertigo?
It's like all allergy or just nasal allergy or any
We'll
allergy?
have to we'll have to make all allergy, obviously not nasal allergy alone because
So one disease which comes to my mind very clearly is Meniere's, like food and vertigo. Yes.
I mean he mentioned autoimmune conditions. The point is one is to have a spectrum and the other is to attribute a cause.
Right.
So to attribute a cause, one would have to come slightly obliquely at it, that you'd have to see benefit of giving anti-allergic as a treatment. So those kind of things we'd have to consider down the road, but let us see if we can get a spectrum. I think that would make a difference. Go on.
Yes. So I think Dr. Nitika Gupta, who has a good amount of experience in allergy, has raised her hand. Can we take her question?
Lovely. Nitika, please. You can put on the camera and
contribute.
yeah,
Actually,
please.
I wanted to contribute in mentioning about patients with allergies and vertigo.
Okay.
In my own personal experience, since I've been practicing allergy for 7 years, and I do also neurotology practice. I have seen a lot of Meniere's patients coming up with definitive histories, and I have proved IgE sensitizations in such patients. And also, I have seen some patients with the food allergy spectrum who on and off have reports of some joint stiffness, the rheumatologist have ruled out all autoimmune disorders. There is no positive history of, there is no positive autoimmune on the test panel, but the patient has a definitive clinical history of autoimmunity. And I've seen such patients presenting with isolated SNHLs associated with few spells of vertigo. So probably was an autoimmune disease and a definitive history of allergy in these patients. I have actually proved IgG
Okay, so here's a couple of
sensitization in few
questions.
patients and given
Yeah, so here's some questions in this regard. Number one,
intratympanic steroids in this patient. I'm so
okay.
sorry, sir.
No, go ahead.
Your voice
Come.
is breaking.
No, no, just a
I have
couple.
actually given intratympanic steroids in such patients with very good results.
Okay. No, wait. There are a lot of questions which I have. If you can spare 2-3 minutes. Where do you practice, Nikita? Which part of?
Sir, Jammu, sir.
You're from Jammu. Great. So here's just a follow-up question. Do these patients present in emergency or with chronic vertigo?
So these are patients. Since I am in a private practice, sir, usually very rarely do I get, because my practice hours are in the evening. So it's very rarely that I get a patient in an acute spell. Mostly what I get is that the patients have had a history of having these symptoms for a few days, or haven't had an attack, and then they have come up to me in subsequent attacks.
Okay, and so
Or as a primary case, they usually land up like they must have had an attack yesterday and they are presenting to me on the next day. So once I take up a detailed history, you get to know that there will be some patients with IgE sensitizations, and history can really help you with that.
Okay, so I mean, we assume that these cases have been treated with conventional treatment, which has not worked.
Yes,
I mean,
absolutely. So
right,
they were patients who were taking medications, who were actually evaluated somewhere else and were not improving. And just in fact, a single dose of dexamethasone intratympanic these patients responded very well.
fair enough. So I think if you don't mind, we'll reach out to you when we are formulating the study. Is it okay with you? We'd like to have you as a member in this group study, because we're really trying to collect data in an area, because everybody bemoans the lack of data in India. Nobody seems to be doing anything about it. So are you okay? Are you open? We'd be happy to
Yes, sir,
collaborate with you.
definitely.
Thank
Definitely, sir. I also, I too have Cyclops equipment only for past 3 years.
you.
4 years we have the equipment.
This is to do with the science. It's good to hear, but the way I'm looking at it is, we look at it from the viewpoint of science.
No, actually, I just mentioned it that I have actually tested such patients with a VNG also.
So that's
I do have
critical.
findings for them.
That's critical to actually making a strong database, because in the absence of a VNG, subjective diagnosis is open to question. So I think that's perfect. Thanks a lot, Nikita. I think I really. Is it Nitika or is it Nikita?
Nitika.
Okay, so I'm still sharp enough. Okay, I've kept Alzheimer's away. Thank you very much, Nitika. I think appreciate it. Um, okay, so let's just attempt a summation, because I think we are coming to the end of a session. So first and foremost, thank you, Mudit, for presenting and making.
Hello. Good evening,
Hello.
sir. Am I audible?
Yes, you are. Who's
Yeah,
speaking?
sir. I would like to ask. Sir, this is Lakshmi.
Yes,
I am an
Lakshmi.
audiologist
Yeah.
currently practicing excessively in the field of vestibular. I am based in Delhi.
Okay.
I would like to ask a question.
Please.
Sir, can you please highlight few points regarding the findings of the VNG so that we can differentially diagnose in a better way? Like what would be the findings of a particular test in order to diagnose?
Mudit, you want to take that on the basis of your experience? If you
Yes.
were to take the patient to a VNG, what would you expect to find in a VNG?
So, what exactly she is asking about is those patients.
What she's asking is, from an audiologist's perspective, when would she raise the bar of suspicion that your vertigo testing is? I know you've been describing a protocol, but she's
Yeah.
asking what are the suspicious events which would flag your concern. So you can broadly say what would suggest Ica, pica, cerebellar versus that kind
Yeah,
of.
so those patients who are presenting within 72 hours, they have got ongoing vertigo, and this is bidirectional nystagmus, unidirectional nystagmus, or they have hence worrisome results, first of all, and some skew deviations also. If some of them are complaining of hearing defects also, then I'll take these patients for video nystagmography. Or if those patient I want to diagnose, if these patients are not in emergency, they are transient vertigo, probably I'll take this patient to differentially diagnose between the other causes of vertigo, like if I want to go for a maneuver or something, or if I am suspecting Meniere's disease or something, probably I'll take these patients for vestibular nystagmography. uh, am I able to explain you what exactly you are asking? Because I
No,
couldn't.
no, it's okay. I think I understand. She's asking broadly what are the
The
areas of
VNG
concern.
findings. I think Ms. Lakshmi wanted to know about the VNG findings.
So findings can be so broad that it's
Exactly.
yeah,
They will differ according to the diagnosis, very
yeah,
honest.
yeah, yeah.
And also whether there
Sir,
is
can you?
pre-existing nystagmus or not.
I'm sorry, sir.
Okay.
If there's pre-existing nystagmus, then the nature of the nystagmus can be picked up in your VNG.
Yeah,
If there's no pre-existing nystagmus and you're relying on provocative tests, then the nature of the nystagmus on provocation tests are the ones which we have to look at.
absolutely, absolutely. Yeah.
No, sir. Actually, I hope, like, I assume that I did not make it clear. I meant, like, suppose let it be a case of vestibular migraine. So I
Mhm.
was asking if, like, suppose it is a vestibular migraine case, then how would I know if
Okay,
it's a
Kripa, I
case?
think you want to take
Yes.
that. You could just describe that. Kripa, go ahead.
Yes, sir. I'll give an attempt. So, what I assume is Miss Lakshmi wants to know the VNG findings. Say, for example, first of all, if you're talking of vestibular migraine, it is a very much clinical diagnosis. Number one, the history will be strong. There will be migraine triggers. There will be family history, possibly a genetic origin. But if you're talking about a VNG finding, then a saccadic pursuit will be there in such patients. But again, then you need to see the patient profile, the age. For example, a young patient with, say, a techie guy with a lot of screen exposure coming with a saccadic pursuit at 32 will point more towards a vestibular migraine. But the same saccadic pursuit in a 60 plus I would think in more in
Mm.
terms of a central finding. I hope I'm
Sufficiently
making sense. Yes.
compendium. So I think we are coming to the end of this.
Ma'am, can you
Sorry, go.
please suggest me few studies or any material so that I can have a deeper knowledge regarding the VNG findings?
Sure. I think we'll,
Yes.
Kripa, could you get across to her
Sure, sir.
directly? Yeah. So we'd be
Why
happy
not?
to do that. We'd be happy
Why
to
not?
do that. And we'd be happy to get your inputs also as to your experience. So, broadly speaking, if I can sum up, we have a very interesting study presented by Dr. Mudit, wherein he has attempted to collate all his cases, especially with those which come to the emergency. And he has attempted a validation of HIMSS plus in his hands in his study. And that I think is a laudable objective. And it's a laudable thing that he has managed to get it published. We also have, in the course of discussion, opened up an area of allergy and vertigo, which we think is going to go forward as a area of study. And we are happy to meet people from Jammu and other places who have some experience in the use of intratrypanic steroids in these kind of cases. We need to, in fact, it's very interesting for me whether intratrypanic steroids, which itself acts as a sedative, um, because the steroid actually sedates the labyrinth. So we used to give injectable steroids post stapedectomy if the patient had violent nystagmus. So steroids is a little bit of protein uh, effect when given, but It's wonderful to hear experience coming in, and hopefully we build it up so that we have something to offer. We also have an interesting opening which has come up on the use of AI and ML in this area. So we have, in the brief period of 1 hour, opened up many areas which are hopefully food for thought, food for research, and food for future analysis. So if any of the panelists or Mudit would like to say anything, I'm leaving the door open to you, and I'll give a brief summing up and we close. Mudit, would you like to say anything?
Nothing much, sir. I have just spoken.
Fine. Kripa?
Thank you so much, sir, and thank you, Dr. Mudit, for that lovely presentation. We really had some food for thought. Yes.
Dr. Rajiv, would you like to comment?
Yes, sir. I think, as you rightfully mentioned, there is a lot of evidence collection going on in the field of neurotology. So, one thing I observe when speakers nowadays, the eminent speakers give lectures, is that hints might be evolving, and there are certain features of clinical examination which are being downgraded in importance. For example, we used to look for saccadic eye movements quite extensively in the earlier, those who were trained maybe 10 years ago. So now the importance of these is diminishing in the lectures of these speakers. And similarly, I think even skew deviation, the importance given to that is reduced. I think basically it's being made easy for people at all levels of expertise to identify and differentiate central and peripheral vertigo. But it's also, I think, the amount of expertise needed to evaluate the patients is being reduced, so that anyone in the emergency setting can utilize the clinical methods to identify the patients. So I think we'll see some changes to the hints. And even in the Cochrane review, which was published in last year, in end of last year, regarding hints examination in acute undifferentiated vertigo. So even in that, they have hinted that there is a problem in the data because they are unable to differentiate how differently experienced individuals would interpret the hints examination. So I think these are some of the things where ML, AI, and devices can help. And there will be, I think, drastic changes in the coming 5 to 10 years.
Okay, so I think that's one thing. I like the word hint. There's a hint that hints may be reevaluated. I like that tautology of words. Number two, I think we should now stop thinking of eminence in this field, because we just need data, and data. I think eminence is a word which has run its course. एक जमाना था where the professor was senior and superior. Now, when I meet youngsters like Kripa and like Rajiv and Mudit, I feel senior. I feel senior to you, but I don't feel superior to you. So I think we need to start re-looking at the whole thing and talking about data, and honest data, and analyzed data. So I would add the word honest. So if you have honest data, whatever it is, it may be totally contrary to reality, but if it is honest, it is honest. And of course, well said that you need to look at history. Again, I think that needs to be repeated every time, that vertigo treatment is history, and history. All the testing is ancillary to the history. So we are also, sorry, would like to say
Sir,
something?
can I ask you a doubt? Yes,
Please.
yes. Can I ask a doubt regarding case history? Sir, when we ask about this is Lakshmi again. Sir, when we ask, hello?
Yeah, go ahead. Lakshmi, keep it brief because we are running out of time.
Sure, sir. Sir, when we ask about the history of fall, so sometimes we get the responses like, I was about to fall, but I took the support, or someone was there to help me, I held someone, or I fell down on bed. So would that be considered as a significant fall?
Anybody could take it. Rajiv?
Uh,
Yes, sir. I mean, the significant fall depends on the age and other things also. For example, if a child fell down on the bed while playing, I don't think it is significant. Whereas if an 80-year-old woman with osteoarthritis and hip fracture fell down, then obviously it would be a significant event. So I think there are certain standard definitions which I don't remember offhand to tell you what
I
is a
suppose you
significant.
would like to differentiate between a rotatory stimulus, a push, or
yes,
a total, a flaccid, this thing. So there are many varieties of falls.
yes, absolutely.
So that you're, am I right, Krupa? Would you like
Yes,
to
sir.
elaborate on
That's
that? Yeah.
yes, sir. So one thing I would just like to, if I can add, would be rather than was there loss of consciousness or was the consciousness preserved? We start with that. In this, the sub question is more important because conscious vestibular falls, if we are talking about, these are conscious falls. Yeah, and by on the other hand, epilepsy, then these kind of things, these are unconscious falls. So that is how it starts with, like, and as you
So
said, flip
I no, I
also.
have a feeling we should reach out to Lakshmi and have one-on-one with her. We'd be happy to
Yes.
do it. Kripa, you could start the process and then we'd.
So I've already shared my mail ID with her.
Sure. Okay. So I once again I thank you all for taking time out on Republic Day, and thank you to all the people who attended. Thank you to Mudit and the panelists, and I would love for all of you all to stay in touch.
Thank you, sir.
Thank
Thank
you.
you, everyone. Thank you.
Thank you,
Good
Thank
sir.
you.
evening.
Good
Thank
night.
you. Thank you.
Night.